Thank you all so much for attending our first Pre-Hospital Guidelines Consortium webinar on implementation science and emergency medical services. I'm Jen Fish. I'm your host. I'm chair of the PGC's Dissemination and Implementation Committee. Just briefly, for those not familiar with the Pre-Hospital Guidelines Consortium, the PGC is comprised of 37 member organizations, along with affiliated institutions and individual members. And the shared goal is to identify the highest quality evidence-based recommendations for EMS and also implement them successfully in EMS systems and agencies, which is very relevant for our topic today. So today is the first in what we hope will be a series of webinars where we'll discuss implementation topics in EMS. Before I welcome our two speakers, there's a couple Zoom housekeeping items. Please stay muted during the presentations. We'll have a 10-minute Q&A session at the end. You can submit questions through the chat to everyone or directly to me, or wait for the Q&A session and then raise your hand with the Zoom function. This webinar is being recorded and will be made available through the Pre-Hospital Guidelines Consortium in the future. And so now I have the pleasure of introducing today's two speakers. So Dr. Manish Shah will speak first about his implementation experiences in EMS. He received his Bachelor's of Science in Physiology from UC Davis and medical doctorate from UC Irvine. He completed pediatrics residency at Children's Hospital Boston and his fellowship in pediatric emergency medicine at Texas Children's Hospital Baylor College of Medicine. He served as a member of the U.S. Department of Transportation's National EMS Advisory Committee from 2013 to 2017, and has also served as a past chair of the EMS subcommittee for the American Academy of Pediatrics section on emergency medicine. He has also served as the director of HRSA's EMS state partnership in Texas from 2009 to 2017, and has been a member of the executive core of the National EMS for Children Innovation Improvement Center from 2016 to 2018. Notably, Dr. Shah has been the PI for several targeted issues grants that study outcomes after implementation of evidence-based pediatric guidelines in large EMS systems in Texas and also statewide EMS systems in New England. Since 2013, Dr. Shah has been the site PI for the Pediatric Emergency Care Applied Research Network, the CHAMP node, which is Cincinnati, sorry, I'm going to mess this up. Charlotte, Houston, and Milwaukee Pre-Hospital Research Node, the CHAMP node, which conducts research in the HRSA EMSC-funded PCAR network. And since 2021, Dr. Shah has been the principal investigator for the NIH-funded PEDI-DOSE study, which is pediatric dose optimization for seizures in EMS. And that study seeks to improve how pediatric seizures are treated in the pre-hospital environment. Following Dr. Shah, we'll have our implementation science expert, Dr. Ramzi Salloum, speak. He is an associate professor in the Department of Health Outcomes and Biomedical Informatics at the University of Florida College of Medicine, and also director of the UF-CTSI's Learning Health System program. He received a PhD in economics from Wayne State University and completed an NCI-sponsored postdoctoral training in cancer care quality at UNC Chapel Hill School of Public Health. Dr. Salloum's work and research considers dissemination and implementation of evidence-based practices in healthcare broadly. He's been funded by the NIH, PCORI, ARC, the Cancer Research UK, the International Research Development Center, Florida Department of Health, and the Aetna Foundation, and has authored over 180 peer-reviewed publications. He's also been an invited faculty member in the NCI's Training and Dissemination Implementation Research in Cancer, and currently serves as the chair of the Learning Health Systems Action Group in the NCI Consortium for Cancer Implementation Science. He is multi-PI in 3 large implementation trials in primary care settings and an expert panel member of the American Academy of Pediatrics Tobacco Consortium. So we will begin with Dr. Shah's presentation, followed by Dr. Salloum, and then our Q&A. So with that, I will turn it over to Dr. Shah.
Thank you so much, Dr. Fish. And I will put up my slides. Okay, can you all see that? Perfect. Okay, well, it's a pleasure to be here today to talk to you about evidence-based guideline implementation in EMS, which is something that I have enjoyed doing for nearly 15 years now. And what I'd like to share with you during this time is how implementation is an essential step in the National Pre-Hospital Evidence-Based Guideline model, and specifically to share case examples from the work that I've done to distinguish most and least effective strategies from my perspective, having done this work over the past decade and a half, and to understand how defining metrics and collecting data are essential to successful evidence-based guideline implementation. And so specifically, I will be referring to three projects, two that, as Dr. Fish mentioned, were funded by HRSA's EMS for Children Targeted Issues Grant Program, are the first two listed there, and then the third being the PDDoS grant that's been funded by the National Institute of Neurological Disorders and Stroke. And I have no financial conflicts of interest to disclose. So in 2007, there were several reports published by what was once known as the Institute of Medicine, now known as the National Academy of Medicine. And in those reports, as a result of them, the National EMS Advisory Council, or NEMSAC, and the Federal Interagency Committee on EMS, or FICOMS, convened a panel of experts, which then proposed this model for developing evidence-based guidelines for the pre-hospital setting. And you'll see that it's got several steps involved, but that first one focuses on evidence-based guideline development, beginning with the input of evidence from various external sources. And then those topics with sufficient foundational evidence are selected for development based on priorities defined by stakeholders. And next, a rigorous evidence appraisal methodology. For example, the GRADE methodology is one that could be used, which stands for Grading of Recommendations, Assessment, Development, and Evaluation, would be used to determine the quality of evidence rating and a strength of recommendation related to specific patient care guidelines that are being developed. And then contextualized patient care protocols would then be generated and disseminated to the EMS community. And after educating EMS professionals on their use, the protocols would be implemented in local EMS systems. And finally, effectiveness and uptake would be measured with quality improvement and outcomes monitoring systems. And so you'll notice that implementation is its own step that I've highlighted there in red, and it's distinct from guideline or protocol dissemination. So my point in emphasizing that is that it's not enough to just put a protocol into writing. Thoughtful consideration must be put into place in terms of how it's implemented. That's crucial to ensure uptake and changing patient outcomes. And this is a lesson that has taken me many years to learn, and specifically how to do that well. I'm still learning, but I feel like with the three examples I'm going to show you, I've tried to make iterative improvements each time. And specifically, if you read this paper by Dr. Eddie Lang that highlights this model, you'll see specifically for the implementation step, it recommends several things. One is developing evidence-based guideline implementation toolkits, webinars, and manuals. Another is partnering with national organizations to facilitate interpretation, application, acceptance by medical direction authorities. Potentially linking implementation to funding and reimbursement, developing health informatics and clinical decision support software, and developing quality improvement measures and tools. And so I'll touch on several of these as I share my own implementation examples, but I'm going to take you to the beginning of where my work in this space began. And though the National Pre-Hospital Evidence-Based Guideline Model was not published until 2012, it existed several years before that. And so in 2009, in order to pilot this model, the EMS for Children program, in collaboration with the National Highway Traffic Safety Administration, funded the creation of the first three pre-hospital evidence-based guidelines to pilot this model process. And so those guidelines focused on pediatric seizures, pain management, and the use of helicopter EMS. And so my first experience working on an evidence-based guideline using this model process was with pediatric seizures, and that's where I learned to use GRADE as an appraisal method, since I was invited to be part of that work group when I was early faculty in my career in pediatric emergency medicine. And so that pilot process took several years, from the point of guideline initiation in 2009 to the point in 2012 when we actually finalized that guideline into a protocol, but then worked to get it published. And finally, in early 2014, it was published in Pre-Hospital Emergency Care along with the other two guidelines that were part of that pilot process on pain assessment and management and the use of helicopter EMS. And 2014, that was the same year that the Prehospital Guidelines Consortium, which is sponsoring this webinar, was formed. And so shown here are the main recommendations from that evidence-based guideline. I've highlighted the two most important ones that we're really emphasizing at the point of initial implementation. And that was the utilization of the intramuscular or the intranasal routes for benzodiazepine administration at a dose of 0.2 milligrams per kilogram, and really de-emphasizing or removing that thought of placing an intravenous line or an intraosseous line initially, since that contributes to delays in care and delays in administration of medication. So I'll come back to the seizure guidelines since that's the focus of that third project that I'm working on now, PD dose. But I just wanted to mention to you where this work began for me, and I, having learned that grade methodology, I then applied that to the subsequent two projects. And so this first project I called Integrating Evidence-Based Pediatric Pre-Hospital Protocols into Practice. And so the first lesson that I learned after working on this grant is that every project needs a good acronym, because nobody's going to remember such a lengthy title. And so since then I have come up with better ones. But this project had a statewide focus with an overall aim to create an infrastructure for developing, implementing, and measuring outcomes of evidence-based pediatric pre-hospital protocols in a state of Texas with independently functioning EMS systems. And so we did this by creating a multidisciplinary team of pediatric emergency medicine physicians, EMS medical directors, EMS clinicians, and we had a parent on the guideline development committee as well. In addition, we did this with the intent of creating an evidence-based guideline in large EMS systems in Houston, Dallas, and Austin. And the reason we did that in urban areas rather than including rural areas was for the purpose of data collection, because we knew that there would be a high volume of pediatric patients in these areas. We intentionally formed this guideline development committee prior to choosing a clinical condition of focus, but the clinical condition that we then discussed as a focus area would need to be something that was common, something where evidence existed, and something where EMS data would be available. And so as we brainstormed through potential options, we settled on respiratory distress as a focus area. And that was inclusive of developing a guideline that would address asthma, bronchiolitis, and croup. And so shown here is the algorithm that we came up with, and this was broken down into several, depending on the EMS agency, it might have been one unified protocol or three separate protocols that focused separately on croup, bronchiolitis, and asthma. And I'm just showing you this here just to show you the complexity of everything where we incorporated all the clinical questions that we considered as we were developing the guideline and how to place it into an actual protocol that could be implemented into an EMS agency. And because of the complexity of this, we did learn some lessons from this. So, I'll reflect on this and say that planning for implementation, we did several things. So one is we converted the content of what you just saw into separate protocols using the EMS system's own format. And so that was essential to ensure that it looked familiar to the EMS clinicians that would be utilizing it. And then we also created an online curriculum to train EMTs and paramedics in each of the systems about the new protocols. And then we plan to collect data from existing records. The process of gathering the required variables we learned was logistically complicated, and it wasn't feasible to have true evaluation of outcomes despite implementing these protocols back in 2012. And so though we were successful in putting new protocols into practice, we also faced challenges in knowing if our change actually made a difference due to the data collection barriers. And anecdotally, however, I observed at my own site the common occurrence that EMS clinicians who transported patients with asthma, bronchiolitis, or croup were often not aware that the protocol had actually changed despite our efforts to implement education around this. And so taking those lessons that I had learned from that first project, I applied some of those things to make improvements in project number two. And so project number two was the Pediatric Evidence-Based Guidelines Assessment of EMS System Utilization in States, or PEGASUS. And so for this, we brought together a multidisciplinary group to develop 4 guidelines, the top 4 that you see there: airway management, allergic reactions, shock, and spinal care. And we also use this as an opportunity to implement 5 additional guidelines from prior work. So the asthma, bronchiolitis, and croup guidelines that we had developed as part of that first project, and then also using the pain and the seizure guidelines that were created from that initial pilot project that was a joint collaboration between EMSC and NHTSA. And so we implemented all 9 of these in the Houston Fire Department in fall of 2014. And then through a collaboration with the state EMS agencies or statewide EMS systems in New England, we were able to successfully implement these in several of the New England states: Maine, Vermont, New Hampshire, and Connecticut. That we had a plan to implement in all 6 states. There were challenges in doing so, but we were able to successfully implement in at least 4 of them. Some changes that I had made in the guideline development process were inclusion of additional members on the guideline development committee. So inclusion of a research nurse and a pharmacist based on feedback that I had received along the way that would augment how we developed the guidelines. In addition, after we had a draft guideline, an improvement we made was being intentional about seeking feedback from professional organizations and statewide EMS and pediatric advocacy groups to ensure that we had considered their feedback in making revisions before we finalized what the actual protocols were. And when planning for education, we included EMS educators in the process and made sure we required 3 hours of in-person training at the Houston site. So this was not feasible to do on a statewide level in New England for all EMS clinicians. But what I did do to at least foster in-person training was intentionally gave presentations about the evidence behind the new protocols at several statewide EMS conferences that were hosted on an annual basis in several of the New England states. We also developed statewide online curriculum that would be implemented using the EMS systems learning management software. And when there were concerns in getting the protocols approved on a statewide level, I learned that traveling in person to meet with the committees that make the final decisions about the protocols and their approval, to explain the evidence and to garner support was essential. And once I had those in-person conversations and explained the evidence, I often found that any concerns that there may have been were mitigated, and we were able to get the protocol approved. And finally, with respect to data collection for outcomes, we focused on what was realistic to get granular data, and we collected data on common conditions such as anaphylaxis, seizures, and asthma, and we focused on data collection in Houston, where we knew that we would also have access to in-hospital data. And so though we were more thorough with our approach with Pegasus relative to the first project, there were still important lessons that I learned even from this one. And one was having buy-in about the evidence that you plan to put into practice is essential. And a mistake that I've made in the past is just relying on the medical director in the EMS agency for buy-in on the implementing the protocols. I faced opposition and delays because I didn't discuss the content of the protocols with broader groups that make the final decisions about implementing changes. And so with Pegasus, I strive to improve upon that by speaking at statewide EMS conferences to really get buy-in from those who are on the front line providing the care, and meeting with statewide protocol advisory committees as well to get buy-in. In addition, having effective training for the end user is necessary as well. And so costs can be prohibitive, I know, to do in-person training. And in the past, I have relied solely on mandatory online training. I found that compliance is variable even with mandatory training. So having in-person case-based training when it is feasible is important. Having a go-live date that implements a change in one or a few protocols in isolation is not effective in a system, I've learned. And so coordinating a go live where it is coordinated with other systems changes that can help raise awareness about the change that's happening. And so for this reason, I had quarterly conference calls with the New England medical directors to plan for training, go live, and data collection. And I also found that a periodic in-person presence contributes to successful guideline implementation, so that myths can be dispelled and questions can be answered about the changes that you're planning to implement. And finally, in order to know if a change is effective, it's essential to collect data on it. And so rather than collect all data that may be theoretically available, it's best to collect data on what's valid and what's feasible to collect. And so simultaneous to the Pegasus project, the National Association of State EMS Officials embarked on a project to develop national model EMS clinical guidelines. And since NHTSA was supporting this effort, they were also highly motivated to have the evidence-based guidelines developed using that national pre-hospital EBG model process to be integrated into these guidelines. And so therefore, all the content from the evidence-based guidelines from my first two projects were integrated into the first version of these guidelines, which were published in 2017. And some states have chosen to adopt these guidelines for use in their statewide protocols. Before I discuss implementation of the third and final project, I did want to touch on an important concept, and I learned around that time that Pegasus was wrapping up this concept. And the model with much of the important work that has been done to enhance EMS care through EBG development until several years ago has been that guidelines are created, quality metrics are measured, and data is collected, but this often occurs in silos. And so most national efforts to create evidence-based guidelines were occurring separately from initiatives to define quality metrics, such as what was once called EMS Compass, and now the more recent work from the National EMS Quality Alliance to develop what data should be collected during an EMS patient encounter. And all of these initiatives have immense potential to enhance quality of care provided in the out-of-hospital setting. But the good news is that we're learning as we work on these initiatives, and we're starting to coordinate efforts. And so the most recent versions of the NASEMSO guidelines also have metrics that have been previously proposed by both EMS Compass and NEMSQA integrated into it, and these have been cross-referenced with NEMSIS data variables when feasible. And so efforts to develop and implement evidence-based guidelines in EMS should really intentionally focus on a coordinated effort such that the evidence in the guidelines drive the metrics that are created, which then impact the data that's collected in EMS. And so as a lead into discussing the third project, the pediatric dose optimization for seizures in EMS or PD-dose study, it's important to discuss the preliminary work that led to what we're implementing in PD-dose. You may recall that my second project involved implementation of the seizure evidence-based guideline that we had previously published. And these guidelines were also implemented in MEDIC, the EMS system in Mecklenburg County in Charlotte, North Carolina, and Milwaukee County EMS also implemented that seizure guideline in a similar manner used in Houston. And so as part of our collaboration through the Charlotte, Houston, and Milwaukee pre-hospital research node of the Pediatric Emergency Care Applied Research Network, we studied the implementation of this guideline to learn what worked and what needed to be improved. And so we compared outcomes in our 3-site before and after study involving 533 patients in these 3 cities. And after implementation, we found several improvements in certain process measures. So for example, across all sites, there was a 20% absolute increase in the use of the preferred intramuscular and intranasal routes after changing the protocol. Also, there was a 10% absolute increase in the administration of midazolam to actively seizing children. However, there was still room for improvement even in these process measures. In addition, nearly half of the patients received the wrong dose of midazolam based on what the protocol at the time stated was the correct dose. We also found that seizure activity upon emergency department arrival was fairly common, occurring in 1/3 of patients. And one of the reasons why patients are still seizing on arrival is many of them are being underdosed. As noted before, half of these children were getting the wrong dose, 75% of whom were getting underdosed. And another reason why seizures may not be stopping prior to ED arrival is that there are delays in midazolam administration. We noticed that the average time to benzodiazepine administration after arrival to the scene was 14 minutes. And so seeing the room for improvement in these metrics, we embarked on a qualitative study where we interviewed paramedics from each of these 3 systems. And we interviewed them specifically to identify barriers and enablers to adhering to their seizure protocol. And 2 specific system level enablers that they identified were having point of care references that obviated the need for dose calculation and the ability to provide medication by more than one route. Several barriers that they noted were the lack of mucosal atomizers or the right size intramuscular needles for infants, protocol ambiguity about whether or not to treat focal and generalized seizures the same, or febrile and afebrile seizures the same. And so paramedics offered solutions to these barriers, and that included simplifying dosing among all routes and having point of care references that match their protocols to decrease the cognitive load required in calculating a dose in a stressful situation. And addressing these barriers by clarifying the maximum pediatric dose, clarifying which seizures should be treated, ensuring that the equipment was there. And so conducting these qualitative interviews in this study with paramedics was helpful to understand the factors that impact real-world implementation, and really provided the insight needed to plan for PD dose. And so the PD dose intervention incorporates paramedic-suggested solutions by using an age-based approach to determine the dose, and completely eliminates the need for calculations. After arrival on scene, the paramedic asks the bystander how old the patient is and uses that response to determine which dose to give, as shown on this slide. And these standardized doses are based on approximate doses of 0.2 milligrams per kilogram, which was in that evidence-based guideline that we had published in 2014. And so this study utilizes a stepped wedge design to stagger implementation in EMS agencies in 20 different cities over a 4-year period, and involves specific training strategies over that 4-year period targeted at improving recognition and care of children with seizures, while also informing the EMS clinicians about the new protocol. So part 1 that you see on the far left in green involved watching an online introduction to the study itself and really defining the paramedics' role in the study, primarily being delivering good patient care. Part 2 is an interactive educational module that is currently being implemented as we do this staggered implementation across all 20 sites, where they watch an interactive online educational module before they attend in-person training. That's number 3, where they go through case-based hands-on training where they practice drawing up the midazolam with a mucosal atomizer or an intramuscular injection. And that is a 1-hour training that's required at all sites in person. And then part 4 is just a brief online yearly refresher module starting after each EMS agency switches protocols until the study's over, to keep paramedics up to date about any interim changes that have occurred. And so in planning for this education, we had EMS medical directors, EMS educators, and paramedics from several agencies involved in the design of the curriculum, and collaborated with each EMS agency to intentionally plan for what's required. And when I go out to each of these sites, I go and I train the EMS educators so that they can then train the paramedics. And I found that when I do that training, we have some very important conversations about the logistics that need to be considered when actually planning for the education and the protocol implementation at the site. So some take-home points: including EMS medical directors, EMS educators, and end-user EMS clinicians is essential for planning for evidence-based guideline implementation. Simplifying protocols and emphasizing key interventions with in-person education is absolutely essential to training. And planning collaboration between EMS and hospitals to collect data is also necessary to ensure that you can collect data on actual patient outcomes. So thank you for listening, and I'll turn it over to Dr. Fish.
Okay, thank you, Dr. Shaw. That was very interesting. Now we're going to have Dr. Salloum, implementation scientist, health economist, speak more broadly about implementation science and how we can apply it to EMS. And just as a reminder, any questions you have for the presenters, please feel free to drop them in the chat, and I'll take note of them for after this presentation.
All right, thank you, Dr. Fish, for the kind introduction and for the invitation to be here with you today. So I'm going to take a step back and talk about implementation science as an approach to being able to address some of the implementation challenges in the EMS setting. And it's a real pleasure to be here with you today. So just start, I have no financial relationships to disclose, and I'm sharing my funding sources. And I'll start with a definition, standard definition that comes actually from the NIH for implementation science. So implementation science is the science of implementation. And it's basically having a deliberate approach to ensure that that evidence-based practices are in fact adopted in real-world settings. And so it's taking existing methods and being able to leverage those methods to close the implementation gap, whether it's on the clinical implementation side or whether it's related to policy. And so implementation science actually covers all settings that relate to healthcare and health. And I really love this recent paper by Jeffrey Kern, who's one of the key folks in implementation science over the past couple of decades. This really simplifies the definition of what implementation science is all about. And I have the citation here. It's really like a one-pager article that is really intended for anyone who is not familiar with implementation science. I recognize that many of you would be here, but I'll start with this. So implementation science makes a distinction between the intervention or the evidence-based practice and the implementation strategy. So the intervention is the thing, and traditional randomized controlled trials focus on understanding the effectiveness of that of the thing that we're studying. So implementation research is focused on how do we get people to actually adopt that intervention or evidence-based practice. So even though we know that there's evidence behind it, that it's effective, it may not necessarily be adopted in practice. So that's why we study implementation strategies more methodologically. So we're interested in understanding how these strategies actually get us to better adoption and scale up of the interventions that we study. And we also we do this by looking at implementation outcomes beyond effectiveness. So we look at the mechanisms behind how these strategies might help a practice be adopted, and also process outcomes and other types of implementation outcomes that go beyond effectiveness. So when it comes to the pre-hospital setting and focus on evidence-based guidelines, Dr. Fish has been very active in this space, and recently published, or a few years ago, published a piece around the challenges and opportunities in terms of implementation of pre-hospital evidence-based guidelines. And so this piece really sets the pace here for implementation research in this area, given the fact that there's incomplete implementation as a result of the really divergent patient populations that are served by pre-hospital settings. The implementation times are substantial when it comes to evidence-based guideline implementation. EMS really covers a heterogeneous set of settings, and so with various levels of resources and other types of characteristics that will influence implementation success. And specifically, the article identifies some of the known barriers to implementation, including coordination among agencies, the challenges with coordination among agencies, financial workforce constraints that are present in any type of clinical implementation, as well as community expectations and some cultural characteristics that are also very important when it comes to any type of clinical implementation. So I'm a researcher by trade, and so I think about where implementation science falls on the spectrum of translational research, and it's really this last frontier in terms of we have discoveries that happen in the lab that lead to the development of interventions, and then we're concerned as researchers in terms of demonstrating the efficacy on a small scale of those discoveries, and then we take them we take them and scale them up to the population level. We're interested to demonstrate that that at a population level, these interventions are effective. But then we stop. Typically, the traditional route was to stop at effectiveness and then just hope for the real world to update those interventions, take up those interventions on their own. And what we've learned is that you really need a push sometimes to get effective interventions into practice, and that's why we need to be more methodological about implementation strategies that can help push these evidence-based interventions into practice. And there's also estimates of how long it takes to get from bench to bedside and then to population, and the estimate, the famous sort of estimate is about 17 years. There's other follow-up studies that have looked at this question and found that it's perhaps improving, that the time to translation has been improving slightly. But the only way to do this is to really start thinking about implementation from the very beginning. And I'm going to talk about the hybrid implementation effectiveness study approach in implementation science. That's kind of unique to implementation science. That advocates for us to be studying implementation at the same time as we're demonstrating effectiveness to help us save time instead of waiting until the effectiveness trial is over to start thinking about implementation. So I mentioned that implementation science is concerned with outcomes beyond effectiveness, and there's different frameworks that help guide us in terms of what outcomes to focus on in our implementation studies. And REAIM is one of those famous outcomes. It's been around for over a couple decades now. There are more recent frameworks that can be used to evaluate outcomes. So REAIM stands for Reach, Effectiveness, Adoption, Implementation, Maintenance. You may have seen this in implementation studies or outside of implementation studies. What I like the most about REAIM is that it starts with Reach, and I don't think that was by accident. Reach is really a key implementation outcome. So if you're not reaching your intended population from the beginning, then you have no chance of demonstrating that your evidence-based intervention is working in that population. So you really need to understand how well are you reaching your target population and be able to measure that if you're concerned with implementation outcomes. And then beyond effectiveness, you go into adoption at the setting level. So making sure that the organizational support is there to deliver the intervention, as well as the individual providers and individual people who are concerned with the implementation, that they are also interested in adopting your evidence-based practice. And then we go into questions of implementation, including how well the intervention is delivered based on the original protocol. So we are interested often in implementation fidelity. And also cost goes hand in hand with every implementation project and is often a barrier and could be a facilitator to implementation. So implementation costs go in that category. And also very importantly is once you step away, does the practice continue within the organization? What does maintenance look like after the initial implementation ends? And so Russ Glasgow was developed REAIM over 20 years ago. A few years ago, published another piece to kind of further demonstrate how REAIM works and why it's really important to measure impact. So that's the table that I have on the right-hand side of the slide. And so you take, and so the example that's provided is hypothetical. You take an intervention that's 50% effective, which is rarely the case in any type of practice that we have. And so taking something that's 50% effective in a controlled setting and then bringing it, introducing it to the real world, you end up experiencing dropouts in effectiveness as a result of incomplete adoption. So typically you're going to have, if you're implementing this on a wide scale, you're going to have challenges with your clinics or your settings adopting it. Not all of your settings are going to be created equal, so they're going to have varying abilities to adopt an intervention. Same thing with your clinics, your clinicians and your staff involved. They're going to have various levels of capabilities, interests, and resources to be able to adopt your program. And the same thing happens with your patients. And if we assume that we have a 50% drop off at every one of these levels, then you take something that's 50% effective in the lab, and in the real world, it ends up being only 1.5% effective. So you see a major exponential drop off in impact as a result of introducing an effective intervention into the real world. And so that's why you need a more concerted effort to manage the implementation process. And at the same time, we have pragmatic trials, which is a concept that goes hand in hand with implementation science. So every implementation science study is pragmatic in nature, and there are tools to help you make your projects more pragmatic. So one of these tools is the Precis2 tool, which is right here on the screen, this wheel that is more of a checklist that you can go through to rate your different measures before you go in and design your study or your project. You should ask yourself, how are participants recruited into the study? Where is it being done? Is the setting representative of the typical setting that this practice would be implemented in? Questions about the expertise that are needed. Does it require specialized expertise that perhaps only large academic health centers have to support the implementation, or can this be really implemented in community settings? So you ask yourself these questions, and there's a 1 to 5 scale. To me, the numbers don't matter as much as the exercise of going through this with your project team, going through these questions with your relevant stakeholders, and making sure that you're engaging them in terms of making the decisions about how you design your implementation project. So we use this regularly in our research projects to make sure that our trials are being pragmatic. So again, in terms of, I mentioned that implementation science has a unique approach, which to research studies, and that's using the hybrid implementation effectiveness approach to clinical trials. And not every study qualifies as a hybrid implementation effectiveness trial, but the idea here is to consider studying implementation alongside effectiveness to close or to narrow that translation gap, that 17-year translation gap. So this is a nice schematic that was published a few years ago, also by thought leaders in implementation science, around which studies are appropriate or which projects are appropriate to be considered for a hybrid implementation effectiveness trial. And typically, you want to have some evidence of effectiveness before you plan a full-blown trial. So, so if you have at least some partial evidence of effectiveness, like a large trial of the evidence-based practice, typically if you're getting into the guidelines, clinical guidelines, and there's some evidence of effectiveness, right? So So those types of interventions are usually appropriate for the hybrid approach. And so if there is some partial evidence to all the way to full evidence of effectiveness, then you want to start thinking about adding implementation as a component. And in implementation science, we differentiate in terms of the level of the hybrid study. And so a hybrid type 1 is a scenario where you have some evidence of effectiveness, but you really need to still focus on effectiveness as your main outcome. So you introduce some implementation evaluations, typically to better understand the context of implementation, the settings that you're implementing. And so once you get to really thinking about introducing implementation strategies, at least you're not starting from scratch. You really understand some of the mechanisms behind the implementation. Whereas all the way on the other side of the spectrum, you have hybrid type 3 studies that are appropriate when you have sufficient evidence of effectiveness, and you're really introducing this practice to a new setting or to a different setting, and you really want to study the implementation strategies in that case. So one example of a hybrid study is being led by Dr. Fish, and so all the examples that I have in my presentation, since my work that my own work that I lead is not in the EMS setting, I'm borrowing all of these examples from Dr. Fish. So this is a NIH-funded trial that Dr. Fish is leading, and is a hybrid type 1 study where that's focused on demonstrating the effectiveness of early administration of steroids in the ambulance setting. And the hypothesis is that this early administration in pediatric asthma patients will decrease hospitalizations, emergency length of stays, and other outcomes. But at the same time, the idea here is that the project is also evaluating implementation, some additional outcomes beyond effectiveness. And again, the study is using the RE-AIM framework to look at implementation among EMS providers, looking also at reach, the percent of patients who are eligible for steroid administration to begin with in the settings that are part of this study, and then looking at individual level adoption among providers, among the agencies at the organization level, and also looking at maintenance outcomes over time. So I know for some of the folks in the audience, this concept of a hybrid study may be new. And so I'll go a little bit more in depth into what the process of choosing a hybrid study. Again, I mentioned that the level of evidence that you have often dictates the type of hybrid study that you want to do. So a hybrid type 1 is when you feel like you don't have sufficient evidence of effectiveness, and you still need to demonstrate effectiveness, whereas a type 3 is when you have sufficient evidence and you're looking to then focus on the implementation strategies, and the effectiveness becomes a secondary outcome of your project. And a hybrid type 2 is somewhere in the middle, where you have a balance of an equal focus on both effectiveness and implementation. Other considerations is how long you expect the intervention will need to be adapted. So if there's a large adaptation process that is expected, then maybe focusing on testing implementation strategies may be something that might need to be deferred to a later phase. And then also, how much do you know about implementation determinants? So if you feel like you really need to study your settings and your barriers and facilitators, then this definitely would be a good reason to focus on the implementation evaluation in your study. And then the other consideration is whether your implementation strategies are ready for prime time. And that will dictate whether your trial will focus on testing the implementation strategies. So implementation strategies, I know I've been talking about these for a while, but they can vary from anything that's low on the intensity scale, like a provider training, or something that some sort of messaging that you provide to your target audience. Or it could be something that is more intensive, like a learning collaborative, or some other resource-intensive strategy that might be needed in your case. Another thing, so besides implementation, a focus on hybrid studies in implementation science. Another unique aspect of implementation science is that we love frameworks, and we often use more than one framework at a time. So I mentioned REAIM as an evaluation framework to see how well we're doing with the implementation. But there are other reasons why we use frameworks. The other reason is that we want to understand the determinants of implementation. And so we use different types of frameworks to understand the barriers and facilitators to help guide us understand the barriers and facilitators to frameworks. We oftentimes also are interested in an implementation science framework to help us to help guide us through the process, and those are called process models. And so this article talks about the distinction between the different types of frameworks and implementation science if you're interested in looking further into that. I know we have time constraints with the talk today, so I'll keep going. Here's an example, again, from Dr. Fish's work. This was a qualitative study that involved conducting focus groups around EMS leadership when it comes to guideline implementation. And so this used a popular implementation research framework, the Consolidated Framework for Implementation Research, or the CFR, as a guide to inform the focus group guides that were used in this study. And so these boxes that you see on the screen are the domains that constitute the CFR. And so these are the different domains that you typically look at in any type of clinical implementation. So you really want to ask questions about the characteristics of the intervention, the implementation process, and the characteristics of the individuals. And then it looks at it divides your environment into two levels. The inner setting typically is your clinic or your immediate setting or your ambulance in this case, and the outer setting is the broader setting that might be relevant. I see a question in the chat about cosmopolitanism. So that's not a referring to a beverage here. It's basically the degree to which your own organization is connected to other organizations that are either similar or relevant to the implementation process. So how, to the extent to which you're part of a network that can provide implementation support. So these ones highlighted in red are the ones that are the individual measures within each domain that came up that came up most frequently in the focus groups. I'll also transition to another example from Dr. Fish's wonderful work. This was a survey, so this was a quantitative study in this case. Happened to use a tool that I really love. It's discrete choice experiments that I've argued in the past that can be a great tool in implementation science to really engage stakeholders around implementation questions. So So this project here was focused on understanding the perspectives of EMS clinicians when it comes to different aspects of implementation. And the way that the study did this is it presented different hypothetical scenarios, 3 of them, and these scenarios represented different levels of guideline implementation. So with the one that you see on the screen, the new sepsis alert protocol, that was representing a brand new guideline that would be implemented. So what characteristics of the implementation would matter to the providers, and so discrete choice experiments are a forced preference technique where respondents have to choose between one option or the other based on the characteristics. And I realize Jen warned me 5 minutes ago to stop talking, so I'm gonna
yeah, I think we have to get maybe wrap up. I'm sorry to cut
we'll
you.
wrap up. I had some additional information about slides about economics of implementation and the role of adaptations that I will skip over. And most importantly, this was my last slide, is that the reason why we do this is it has been implicit in implementation science work that this work is really to advance equity in health equity. And over the past few years, this has become more explicit in implementation science frameworks. And so just a reminder about why we do this is really to reduce health disparities and advance health equity at a population level. So thank you again for.
All right, thank you so much. And we do have a couple minutes left. I've been getting some questions. I'm going to put contact information for all of us up on the screen, as well as the Prehospital Guidelines Consortium's website. Hope to make this video and the slides available on that website sometime soon. So I got 2 questions, one for each of you. So Ramzi, do you have any suggestions for formal or informal implementation science training for an EMS professional, whether that's someone who works day-to-day at an agency or someone like myself and other listeners who do EMS education and research?
Sure. So that's a great question. So from a researcher perspective, I think these are 2 different sets of resources that would be available. So increasingly for researchers and folks interested in implementation research, there are trainings that have been funded by NIH and others. They go through various cycles in terms of the funding. So I started out in one of those training programs, and I'm happy if anyone is interested to put you in touch with different programs. We also have formal coursework and education programs at UF and other universities for that. In terms of actual training for actual implementers, I know a little bit less about that. There's a new actual textbook that is targeted at implementers and folks working directly in implementation rather than people like myself, researchers. And I'm happy to share the information about that book with everyone. I think that the conferences themselves are a mix of researchers and practitioners. So I also, the large conferences, the Academy Health D&I conference usually happens in the DC area every December. So that's usually a great conference because it's not just a bunch of researchers. There's a lot of implementers that present their work and participate in that meeting. So I invite everyone to check that out. There's also, I'm sure, trainings that I'm not familiar with, but I can look into that.
Okay, thank you. And then in our last minute for Manish, if you had to implement a new guideline tomorrow, what are sort of your 3 take-home points, or if you were advising someone who had to update their SOPs that you've learned over those projects you described, maybe common pitfalls or just big pieces of advice you would give people?
Yeah, I would say one of the things that I said in my original take home was inclusion of not just the EMS medical directors, but the frontline EMS clinicians as you're designing things, because they're going to give you insight about the nuances of just perspective, behavior, when you're actually utilizing a protocol. And so their perspective is valuable when planning for things. And then I would say, as well, I think that people appreciate understanding the why, and I think you had found this in your own work yourself when you did the qualitative study, is that people want to understand the evidence, and so you garner buy-in with the frontline and the medical directors when you're implementing something if they understand what is the evidence behind it and you explain it. And I think that doing that during training, ideally in person, is impactful.
Great. All right. Well, we'll end on that note. It's 1 o'clock. Thank you, everybody, for your time. Thank you to our presenters. Really appreciate your time and effort. And visit the Prehospital Guidelines Consortium website and stay tuned for more news on a second webinar.
Thank you.
Thank you,
So
everyone.
much.